Well, well, hello. I was just taking a walk on the beach and how nice to see you. I know what we should do. Let's talk more about small animal medical nursing. Yeah, okay, here we go. Well, this time around, we're going to talk about the gastrointestinal system and the liver and gallbladder and pancreas, as well as the urinary system. So to begin, if I show you a little procedure, if we were having class face-to-face, we would actually practice part of this procedure. I'm not going to tell you what it is. I thought we could just maybe watch it and you can say, what the heck is going on here? So they're palpating this little cat's neck and they're stabbing a scalpel blade into his neck. And then they're pulling this tube from inside of his, they're pulling it first into his mouth and then they kind of turn it around. What are they doing? Well, you will find out. You will find out today in Small Animal Medical Nursing Part 2. And as I said, we're going to discuss these diseases. We'll talk about placing esophageal feeding tubes and the purse string and Chinese finger trap suture pattern. And we're also going to calculate caloric needs for feeding. Kind of a short little bit of math, but useful. Useful for this cat, useful for all sorts of patients. So these are the disorders that we'll talk about first. And just thought I'd just show you this little video of this little dog here and see what you notice about him. Okay, well, kind of a little puppy, it looks like. Very, very determined. And then he just kind of reaches the wall and just kind of stands there. What's going on? And he just kind of paces along. So you can picture him kind of maybe imagine him pushing his head against the wall. We'll talk more about what's going on with that little guy. We have this case that we're going to begin with here. Name's Cal Drogo. He's a 11-year-old male neuter domestic shorthair. The owner reports that he did not want to eat today, and he is hiding some more. I have a study notes, but I think you may not be able to print where you are, so I may not actually use the study notes. I may just try to read them to you here. So just based on this, right? Owner brings you his cat. Cat's not wanting to eat today and is hiding more. You know, what are some questions you might want to ask him? It's always good just to begin with the basics, right? Is he indoor? Is he outdoor? What does he normally eat? Is there anything he could have gotten into? You know, it's always good to ask the owner what he or she thinks. You know, is he on flea and tick prevention? Has he eaten anything unusual? Things like that. Has he traveled anywhere? All those sort of usual questions. In this case, no, there's nothing. There's nothing. He's an indoor cat. He's current on preventive care. There's been no other cats around. Owner hasn't seen him eating string or anything like that. So you do a physical exam on him. Let me just back up here. You do a physical exam on him, and here's what you notice. You notice that he weighs about 11 pounds. Hold on here. Okay. You notice he weighs about 11 pounds, but the last time you saw him 6 months earlier, he weighed 12 pounds. So he's lost a pound. When you are palpating his abdomen, he kind of grunts and flicks his tail when you're palpating the cranial abdomen. Then you do it again, and he doesn't grunt again. And he also has mildly increased skin turgor and slightly tacky mucous membranes. Well, obviously, the last part, he's a little dehydrated. Um, that little grunt probably means he's painful. And I don't know why, but you would think that if you palpated or touched the same spot a second time, that your patient would react the same way, but they don't. Um, um, that's just a general observation I want to make, because you'll be checking a patient and they'll do something and you'll think, did they just do what I think they did? Did they grunt? Or did the tail flick? Or did the ears go back? And you'll do it again and they may not do it, because they're trying to hide pain. So I always try to be very observant when I do things, because I may not get a second chance. What about the fact that he's lost a pound? Well, that makes me wonder if maybe this, whatever's going on, didn't just start yesterday. Maybe something's been going on for weeks, but it was so subtle that nobody would notice, because you don't lose a pound in one day. This is from the start of the chapter. It's just kind of a good review of certain terms, right? Certain terms that you'll be hearing involving diseases. So all diseases have an etiology, pathogenesis, and clinical signs. They sometimes, some diseases, it's a little hard to use these terms to describe. And in today's lesson, I'm going to sometimes combine clinical signs with technician evaluations. They're totally different things, but there's some overlap, as you'll see. So etiology just means the cause. It's the cause of a particular disease, and then that is basically getting the ball rolling, and that leads to pathogenesis. So the book gives heartworm as an example. Dirofilaria immitis is the cause of heartworm, but there's more to it than that. Once your patient gets heartworm, other things happen. The worm causes inflammation and obstruction, right? That's the pathogenesis of heartworm disease. And I find understanding pathogenesis helpful because it's a crystal ball. It lets me know what I can expect and watch out for and tell the owner about. For example, if a patient gets into rat poison, well, the etiology is the rat poison, right? It's the vitamin K antagonist that's going to then lead to the pathogenesis of rat poison, of rat poisoning, that without vitamin K, certain clotting factors, without vitamin K, the liver can't make certain clotting factors. And so the pathogenesis is now the patient's missing clotting factors, and they run the risk of having a bleeding disorder. So what's the crystal ball? Well, the patient could start to bleed into their abdomen. They could bleed into a joint. They could bleed into their eyeball. They could bleed into their chest. They could have weird bruising. Even if I'm not seeing any of that, I know to look for it. You know to look for it. We know to warn the owner, to watch for difficulty breathing, a distended abdomen, things like that. That's why I find pathogenesis helpful. And then clinical signs, you might want to call them symptoms, but technically the symptoms are different. Clinical signs are identifiable body responses to these pathologic events. And sometimes patients don't show any outward signs of disease. Most of today's diseases, though, um, you will be seeing some clinical signs. I wanted to show you this. The book discusses the technician practice model, and that actually it comes from the human nursing side of things. They developed the nursing process, and it's the same thing. And I just thought this was a good I thought this was just a good little flow chart. You know, beginning with assessment, you're collecting data. We get a diagnosis. How are we going to manage? You know, the patient. What's the patient's response going to be to disease? How do we help the patient and the client? And then, is it working? Is the patient getting better, or are they getting worse? So, it's a cycle here. So let's just start by talking about some of the common clinical signs we see with gastrointestinal disease. This is just a partial list. There's more in chapter 19, like hematochezia. So I just wanted to talk about a few. One is last week we talked about how vomiting and coughing can look similar and how to tell them apart. There's also regurgitation. And regurgitation and vomiting are two different things. They both involve stuff coming up from the digestive tract, but regurgitation is a passive event. And so when an owner comes in and says their patient is vomiting, they might not be vomiting. This dog, for example, has a disease called mega esophagus. Now, we're not going to talk much about mega esophagus, but it involves a big, enlarged esophagus. And these patients will eat, and food will just sit in their esophagus. And then an hour or 2 hours later, it just kind of comes out. There's not a lot of it just maybe a little activity, and then all this undigested food comes out. So you'll see in this guy, just like there's just chunks of, there's no bile, there's no stomach acid, it's not green or yellow. It's basically, there it is. It's basically what he just ate, just big chunks of meat coming out. Right? That is not normal vomit. So again, regurgitation is a passive event. Probably the most common time you'll see regurgitation would be this condition called mega esophagus, where the food never even, it never reaches the stomach. But there are other kinds of other causes of regurgitation. Another thing that's important to differentiate is constipation versus tenesmus. A lot of clients will think their animals are constipated because they'll see them straining, squatting down, and they'll think, oh, they must be constipated. Well, tenesmus is kind of the opposite of constipation in some ways. So tenesmus, most of the time, again, the patient is squatting and they look like they're straining to defecate, but nothing's coming out. Most of those patients are not constipated. They actually have colitis. They have inflammation of the colon. They feel like they need to defecate just because it burns and is so irritated. They usually have colitis, diarrhea from colitis. Although tenesmus can also be caused by straining to urinate. And I'm going to show you some pictures in just a second. And then another thing we'll talk about is you can learn a lot from diarrhea. And if a client brings in their pet and they have diarrhea, there's certain questions we can ask to determine, well, is the diarrhea coming from the small bowel, meaning the small intestine, or is it coming from the large bowel, meaning the colon? And we'll talk about that too. So again, let's look at these two patients here. This cat and this dog, this is tenesmus, right? They're just both kind of squatting and straining. And they could be constipated. They could also have colitis. They could also have some sort of a urinary tract obstruction or inflammation. We can't tell. All we can tell is they're straining to either urinate or defecate. So this is what tenesmus can look like. Often tenesmus, they're shaking, and I mean it's they're really trying hard to urinate or defecate. I prefer to think of tenesmus as straining to defecate. When I think of straining to urinate, I prefer terms like dysuria and stranguria, but the book describes tenesmus as either one. So okay, I couldn't find a good picture of a big pile or big puddle rather of diarrhea, so I made my own. So let's talk about small bowel versus large bowel diarrhea. The most common kind of diarrhea you will see will be large bowel, and that means, again, colitis, so inflammation of the colon. Giardia will do that. Dietary indiscretion, the dog eats something that's upset their stomach, that will cause colitis. Whipworms will cause colitis. And so we get mucus and frank blood, also called hematochezia. The patient will defecate more frequently, but but a smaller amount. So more frequently, less volume. There will often be an urgency, like they can't hold it. They go in the house. That's large bowel diarrhea, and that's usually less serious. Small bowel diarrhea is a greatly increased volume of diarrhea. There's usually no blood, there's no mucus. The dog or cat may only go once or twice a day, the normal amount, sometimes more often. There's just a lot more of it. And there's often weight loss involved. So small bowel diarrhea, we can associate with things like inflammatory bowel disease, or worse, some sort of a diffuse cancer of the small intestine, lymphoma of the small intestine, for example. And so we want to ask questions like, how frequently is your dog or cat going to the bathroom? Do you see blood? Is there mucus? Um, Things like that. Is it, check the chart. Are they losing weight? Okay. Now, that's clinical signs. In general, how do we diagnose some of these gastrointestinal diseases? A concept I don't know if we've ever used before, but you'll hear it is this term, the minimum database or minimal database. And that refers to the diagnostics that just about any problem could benefit from. The book calls the minimal database or minimum database a CBC, chemistry panel, and urinalysis. I've heard other people refer to the minimum database as being those same three plus radiographs and a fecal analysis. Like those 5 things, and possibly you could include a leukemia test in cats or heartworm test in dogs. Those are considered the minimum database. Like any sick patient, you can justify all of those tests, and you certainly can. There are more advanced tests that we might do. If these don't give us the answer, we can do the SPEC FPL or CPL. You learned about that last year. That's to diagnose pancreatitis. The FPL stands for feline pancreatic lipase. CPL stands for canine pancreatic lipase. Folate and cobalamin, those are vitamin B levels that can tell us a little bit about the health of the intestines. There may be infectious causes of gastrointestinal diseases. So we might be looking for certain viruses, certain bacteria, such as salmonella. There are certain parasites like whipworms that we might need to do an ELISA on, because whipworms are, you remember, they don't lay eggs daily. So we have to do sometimes an ELISA, maybe a Giardia ELISA. There are even fungal causes that I'd have to check what the tests are. Imaging, there's you all did contrast radiographs last semester. You gave barium. I forget to which patient. There's endoscopy. You can use endoscopy to do a biopsy. We can also do a laparotomy surgery to do biopsies of the intestines or the colon. Now, the gastrointestinal tract is a challenge, and this is important because it helps clients understand that some of these are not easy diagnoses. The gastrointestinal tract is basically outside your body, right? This is a tube that runs through the body. Technically, it's outside, and when things are outside the body, blood tests are not that helpful. Blood tests, urinalysis, they don't tell us a lot about the gastrointestinal tract. They're great for the liver, they're great for the kidneys, they're great for a lot of things, but not for the intestines, not for the stomach, not for the esophagus. So that's important for clients to know. It's also important to know that lots and lots of non-gastrointestinal diseases will cause vomiting and anorexia and diarrhea. Later, we'll learn about, kidney failure. Those patients are vomiting. You've learned about Addison's disease. That's a hypoadrenocorticism. Those patients can look just like they have, in any disease. It's the great pretender. So when I'm working up gastrointestinal cases, I always have to remind myself that the problem can be inside the gastrointestinal tract, or it may have nothing to do with the gastrointestinal tract. So just as a review, barium is that special liquid that lights up when you give it to a patient. So here you can see the stomach and the duodenum are outlined by the barium, and it moves through the intestines pretty quickly. Here it is now in the stomach and the duodenum and jejunum. What is wrong with this patient? Well, this is megaesophagus. So you're looking at a patient on their side. They're in lateral recumbency. Their head is over here. This is their thorax, and this is the esophagus. The esophagus should normally, be a very thin, little structure, right, going down to the stomach. This esophagus is all stretched out, and the barium's just sitting there. Barium studies are also useful for finding foreign bodies. So this dog ate some sort of a round ball, and can you tell by looking? Again, I'm going off the word of the veterinarian who posted this. So just by looking at him, there's barium. Can you tell where the obstruction is? It's not a complete obstruction. Barium can still get around it because you can see the barium is making its way down here to the colon, but apparently it's right there. Now so right here, there's some sort of you might not like me outlining that, but so barium is very useful for things like that. Okay. Anyway, this has nothing to do with the diseases we're talking about, but I thought it would be useful for you to see barium in action again. I also wonder, what's this thing? But we don't care. Okay. And then I thought it'd be useful to see endoscopy in action. In this video, they're removing a little foreign object from a dog. I think they tell you what it is right away. But they're using, again, a camera, and I call it a pickle grabber, but it's a special little device they're using to remove this object. So let's watch this. There's no subtitles. So what is that? I'll give you a hint. It's probably around December, early January. So there's endoscopy. Right, Dr. Villalobos is going in. We're in the little dog's esophagus. There's this thing that's obstructing the esophagus. Dr. Villalobos there's the pickle grabber. It's not really a pickle grabber. They're really forceps, I guess. And so that's actually part of a Christmas ornament. That's the little thing that goes in the ball, Christmas ornament, the little prongs. So that's what this little dog swallowed. But there's the endoscope. Let me just pause that. Oh, I can't. There we go. So there's not the endoscope, but there's the probe, and there's somewhere in there is a little camera. I'm just showing you that little part of the Christmas ornament. I thought they showed us, okay, I thought they were going to show us a little more of the endoscope, but anyway, there you go. So again, these are other things we can use. You know, if the CBC chemistry panel, urinalysis, if it's not giving us an answer, we can actually go and look. We can look. We can get a biopsy of the stomach or the small intestine, and that can sometimes give us our answer. So let's go back to our little friend Cal Drogo here. So the veterinarian, which was me, ordered these tests, and so he had a mild neutrophilia, and chemistry panel, the FPL was normal. He had a moderately elevated BUN and creatinine, very concentrated urine. He had 1+ bilirubins, and remember, bilirubin can be normal in a dog. It is not normal in a cat. It can be normal in a male dog, but it is never normal in a cat. Abdominal radiographs were unremarkable. I am pretty lousy with ultrasounding the pancreas, so I actually had the client go to have an ultrasound done because I thought this cat really seemed like it had pancreatitis. And the SPEC FPL test is great. It is great, but it's not perfect. And so the owner agreed, and the ultrasound showed that the pancreas was thickened and irregular, and I couldn't find a good picture. It was actually the picture I'm going to show you. It's hypoechoic, but the pancreas that I was shown was actually hyperechoic. It was more dense than the surrounding tissue. So here we are. Here's an ultrasound of a normal pancreas, and you can see how it's, there's the right kidney, and that's the right part of the pancreas. Anyway, this was the patient's, or this is what the pancreas could look like. It's much thicker. It's kind of irregular. It's a little more hypoechoic, probably because it's full of water and not water, but it's full of fluid. So what does the pancreas do? Let's just kind of review what the pancreas does. It's sort of two organs in one. Um, there's the endocrine pancreas and the exocrine pancreas. The endocrine pancreas makes insulin and glucagon, but we don't care about glucagon. We care about insulin. Um, the insulin, its job is to shuttle blood sugar into your cells so they can use it. Um, and we're going to talk more about that next week. Today, we're talking about the other part of the pancreas, which is the exocrine pancreas. Again, endocrine means releasing substances without a duct. Exocrine means releasing substances through a duct. So sweat glands are exocrine, salivary glands are exocrine, and the pancreas is exocrine because it puts all these digestive enzymes through a duct into your small intestine so you can digest whatever you ate. It makes lipase to digest fats, lipids. Um, lipids are fats. It makes amylase to digest carbohydrates, and it makes trypsin to digest protein. Protein. Remember that. Um, so, what can happen with this first disease and the disease that Cal Drogo had was the pancreases started to digest itself. So these enzymes have become activated while they're still in the pancreas. That's not supposed to happen. In particular, it's trypsin. The enzyme that digests protein is digesting the protein of the pancreas. So you can imagine, how would this feel? It's probably incredibly painful. Um, so First, the etiology. Most cases in dogs and cats are idiopathic. They happen for no rhyme or reason. Sometimes in dogs, it is from eating a high fat meal, what we call dietary indiscretion or garbage gut sometimes. But sometimes the day after Thanksgiving, we see dogs with pancreatitis because they got a hold of the turkey and the gravy and the mashed potatoes. Um, there are less common causes. They're possible, but they're less common. As I said, the pancreas is digesting itself. That leads to a lot of pain. That would be one of the clinical signs. But I'm going to use these two new terms. One term is sequela, or maybe it's pronounced sequelae. I don't know. But it's basically a consequence. So sequela means consequence. And a consequence of pancreatitis is your patient can develop low blood pressure. I don't know why, it just happens. We know that pain can lower blood pressure, so maybe it's related to that. Pain can also raise blood pressure. Pain and blood pressure are a little complicated. Um, Pancreatitis can cause disseminated intravascular coagulopathy, right? That horrible clotting disorder that we sometimes call death is coming. It can cause renal failure. Just all of, again, it's way beyond the time we have, but pancreatitis can set off some savage domino effects around the body. We also worry because in a cat, it'll make them stop eating, and that can lead to a whole new problem called hepatic lipidosis that we'll talk about in a minute. So some of the clinical signs we already mentioned, pain, certainly those are things that the patient may not, the owner may not realize their pet's in pain. They don't show pain the way we do. So that's something to be mindful of. Um, the they're, they may be vomiting, they may be dehydrated, um, um, they may be lethargic. So these are all things we may see with with pancreatitis. To make a definitive diagnosis, you would need to biopsy the pancreas, but nobody ever does that. So we can make a presumptive diagnosis based on the pancreatic lipase test. If that's negative, but we really suspect pancreatitis, ultrasounds are very helpful. Some people can see if it's really bad on an X-ray. You may just notice a little bit of kind of a blurry appearance where the pancreas should be, but I've never been able to spot that. So I really like the lipase test. Treatment is mostly supportive, and the pancreas has to settle down and heal itself. Pain control is a big part of the treatment. There are antiemetics we can use. Do you recall there's a particular antiemetic that also has some special analgesic powers? That's meropitant, also known as Sorenia. That's a little bit of a wonder drug. Nutritional management is important. Now, this applies for dogs. Sometimes they'll actually have dogs. We'll try to feed them a bland diet or a low-fat diet. I should say bland and low-fat. Cats, it does not have to be low-fat. In fact, we don't want it to be low-fat in the cat. We want them to just eat whatever they'll eat. It can be high-fat. It might be better if it's high-fat. And what do you do when a cat won't eat? It's very tempting to force feed the cat, but that will almost never work. The cat will hate whatever food you try to give them, and they will never eat it on their own. And it is really hard to get enough calories into a cat. I confess, I have sometimes had owners force feed, but I'm aware that if that cat doesn't start eating soon, we need to take more aggressive measures. Cats, sometimes, if they would just eat, they would feel better and then they would want to eat. So you'll see people applying food to their nose and a cat licks it off. There's little things we can do that if we just get them to eat, sometimes that primes the pump and they will keep eating. But sometimes it won't. And that's where this comes in. So this was the placing of a feeding tube. This is something that veterinary technicians can be heavily involved with. Frankly, except for that one little initial poke, you could do it all. What we were going to do in class was learn the suturing technique. Well, we can't do that, but I think it's still worthwhile seeing because you'll see this again later today. So this is called the, here they're placing a drain, a passive drain, but they're using the same pattern. So there you are, we just stabbed the patient's, the skin in their neck. And then you're gonna see, I'm gonna speed this up a little. So they're doing a purse string pattern going around the esophageal feeding tube. The esophageal feeding tube is they're just using a red rubber catheter. So it's nothing special. They go around that, and then they have equal lengths of suture, and then they just crisscross after they tie the purse string, make that nice and snug, coming out of the cat's neck. Then we take equal lengths of the suture and we just kind of, crisscross around and around the tube, placing square knots after every couple of after every time you go around. if you've ever, as a kid, seen the Chinese finger trap, it's this little paper structure you put both fingers in, and when you try to pull your fingers, it tightens around your fingers. That's how this works. If the cat, or somehow, if this tube, if someone tugs on this tube, it should not come out, because when you tug on it, that suture will bite down into the esophageal feeding tube, and it'll keep it in place. So, very satisfying thing to do, and really a life-saving thing to do. Then again, I just thought you would find this interesting. Once you place the tube, a big part of what the veterinarian and RVT do is teaching clients how to feed these patients. So for patients with with um, with pancreatitis, really any cat that is not eating can benefit from one of these tubes. They can stay in for weeks or months. The client just has to check the site. We flush the tube with a little water. The client does this at home. They can just flush the tube with a little water first. And then there's special foods we can use, like AD, which is kind of a soft pate. And just little by little, you don't want to slug it in there. You just give a little pulse of food at a time. If you give too much, the cat will just, it may just come out of the cat's mouth. So just little bits at a time, and then some more water afterwards to clear it all out. And then you put the little plug back on, and that's it. The cat's eaten. And the first time I did this, it was a cat that hadn't eaten in a week. The cat had hepatic lipidosis. Um, and we placed the tube in, and literally after the first 24 hours, that cat wanted to eat again. He was eating even with this tube going down his esophagus. So it was a very satisfying experience. Okay, anyway, that's pancreatitis. That's our first disorder, and I just wanted to show you feeding tubes. Even though feeding tubes, there are different feeding tubes. Some can go in the jejunum, some can go in the stomach, but the most common one, I believe, is the esophageal feeding tube. Okay. Here's a condition. We don't see it as much as we used to, but you will still see it. This is again a problem of the exocrine pancreas. Here, the exocrine pancreas is just not making digestive enzymes. So it can be congenital in some dogs, in particular German Shepherds, but other breeds as well, where the pancreas just kind of atrophies. And cats, we see it if they've had chronic pancreatitis. Let me just back up here real quick. In fact, I wanted to say one last thing about pancreatitis. So you'll notice that Khal Drogo also had that 1+ bilirubinuria. We'll see that some of these diseases can have other problems at the same time, or can lead to other problems. Some patients with pancreatitis can also have a little hepatitis too, but we'll talk about that a little later. Okay, so chronic pancreatitis in cats, it's a whole other problem actually. Chronic pancreatitis in cats is really hard to diagnose. These cats, they may not be vomiting, they may just be eating a little less, or they might be vomiting, once a week. So chronic pancreatitis probably flies under the radar a lot, because it can be hard to diagnose. And the pancreas just has this smoldering inflammation, and it can eventually lead to exocrine pancreatic insufficiency, where the cat just isn't making the enzymes anymore. So what do we see? Well, we see these patients, and this is really probably more true for the dog. These guys are hungry. They want to eat all the time. So again, what's my technician evaluation? I want to make sure this patient has plenty of food because they are just going to be wasting away. So if they're there for the day, make sure they always have food available. They're going to have this kind of greasy looking poop. It's called steatorrhea. And steata or steat means it's a kind of another word for fat, kind of. But their poops will be this kind of pale color. They'll be kind of fatty looking, and there'll be a lot of it. They are not normal looking poops. I should have given you a picture. And the way it's diagnosed, it's, I believe, fairly easy to diagnose. It's we measure a different enzyme. Instead of lipase, we measure the trypsin levels. Now, I don't know why for pancreatitis, why it's the lipase test and not the trypsin test. It just is. For this disease, we measure trypsin levels, and they will be really low. How do you treat them? Basically, you feed them powdered pancreas. They take pancreas from some other animal, like a pig, and they make a powder, and you just put a couple of scoops in their food, and then these patients will just thrive. In cats sometimes need cobalamin injections too. Cobalamin is made by the small intestine, and it's kind of a long story. So we give these cats vitamin B12 as well, which is the prettiest little drug. It's this beautiful kind of reddish color. Anyway, remember the dog we saw near the beginning, the dog who was kind of pacing and just pushing his head up against the wall. So let's use him to introduce the hepatobiliary diseases. And hepato refers to the liver, biliary refers to the gallbladder and the bile ducts. And these are the diseases we're going to look at. Feline hepatic lipidosis, canine chronic hepatitis, portosystemic shunts, and then feline cholangitis, and I didn't put it on there, but also hepatocholangitis. The clinical signs we associate with these liver and gallbladder diseases are similar to some of the gastrointestinal ones, right? Vomiting, lethargy, but icterus will be unique to these. Hepatomegaly, an enlarged liver, would be unique. And then ascites, fluid building up in the abdomen, would also be unique. And there's one particular clinical sign that's also unique, and that's called hepatic encephalopathy. And so again, hepatic referring to the liver, encephalo referring to the central nervous system, and pathy referring to a disorder. And this happens due to ammonia levels building up. So you recall, you eat protein, this little guy eats protein, and it gets broken down, and ammonia is made as a byproduct. Ammonia is really toxic, but your liver turns it into blood urea nitrogen, also known as urea. Well, if your liver is sick, it can't do that. And so what happens is your urea levels, well, what happens is your ammonia levels go up, and it causes these mental, these kind of mentation clinical signs, head pressing, circling, pacing, ataxia, seizures, I misspelled. They're usually kind of lethargic. Some are in a coma. It can be treated if it's not too severe. There's a laxative called lactulose. It's a sugary laxative. We use it in cats with megacolon. It's a really great laxative, but it also will inhibit the production of ammonia and the by bacteria in the intestines. It's kind of cool. And in a pinch, we can actually give it as an enema. Other things we might do is our low protein diet, so the patient makes less ammonia, and then probiotics can sometimes help by getting some good bacteria in there. How do we diagnose hepatobiliary diseases? I'm pulling here from your first semester clinical lab skills. You remember there are certain liver enzymes. Some enzymes go up when there's damage to hepatocytes. So ALT and GGT, they are located inside. Wait, I'm sorry. ALT and AST is what I should say. ALT and AST, they are inside the liver cell, and so when the liver cell gets damaged, those levels go up. ALP and GGT are actually on the membrane of the liver cell, and they go up if there's something that's obstructing bile flow. So liver enzymes can help us. There's the liver function tests. They answer the question, is the liver doing what it's supposed to do? So things like glucose. If glucose is normal, well, then we assume the liver is able to store and release glucose. But with liver disease, glucose will go down. Urea will go down because the liver's not making urea. Cholesterol will go down because the liver's not making cholesterol. Other things will go up, like bilirubin will go up because the liver's not processing the bilirubin like it's supposed to. Albumin will go down because the liver's not making albumin. So we call those the liver function tests: glucose, urea, cholesterol. This dog is not in liver failure. Okay, I'm just showing you these. But with liver failure, urea, glucose, albumin, and cholesterol would all be decreased. Bilirubin would be increased. And we can also use urine. If we find bilirubin in the urine, that can be abnormal. And there are even certain crystals that show up, but that's not very common. And treatment, of course, will depend on the disorder, but there are some general things that apply to several different diseases. The liver is frustrating because we've got a lot of heart medicines, right? You learned about furosemide and pimobendan. You learned about amlodipine, and there's all sorts of cardiovascular drugs, ACE inhibitors. There are really almost no liver drugs. If the liver is sick, there's not a lot we can do for it. There is one drug that we use for liver diseases, and that's called denamarin, and it contains these antioxidants. We call one SAMe, that's that S-adenosylmethionine. It also has a drug called silibin, which is made from milk thistle. In fact, you'll see some people and some veterinarians prescribing milk thistle, which is some sort of a plant. So these have an anti-inflammatory, they really have, these are having an antioxidant effect to help protect the liver. Sometimes antibiotics will help, fluid therapy. Some of these patients get the ascites, the big fluid buildup, and we can actually drain the fluid. So those are some general things. Okay, hepatic lipidosis. The etiology is any cat with prolonged anorexia. Cats are not very good at burning fat. You and me and a dog and most animals, if they're not eating, well, we want them to eat, but they could probably go, we don't want them to go a week. We don't want them to go 3 or 4 days. But if they went 3 or 4 days without eating, they'd probably be okay. If a cat goes more than 2 or 3 days without eating, we're going to start to worry about hepatic lipidosis. they start to mobilize fat. They're burning fat to provide energy, but their liver gets overwhelmed. It's just not that great at metabolizing and processing all of that fat. And so the liver, well, I'll show you a picture, but all this fat starts to build up in the liver. Um, um, any cats at risk, obese cats are more at risk, but this can happen in any cat. It can be from some sort of environmental stress. It could be from a torn nail, anything that would make a cat not eat. Often it's something like pancreatitis or you know, something involving the pancreas or the liver, although some cases we don't know why it happened. Diagnosis, it can be made off of the history, the physical exam. These patients will often have a really large liver. The chemistry panel may help us. It's a presumptive diagnosis, but if the pancreas looks okay, um, the liver function tests are normal, then we start to think, okay, maybe it's hepatic lipidosis. Treatment is often placing that esophageal tube, just getting food in there so that they can stop burning fat. Um, so this is a normal liver, right? Here's a normal liver, and you can just see the sharp edges on the lobes of the liver and the nice dark color. Here's, this is actually a cow with fatty liver. You see how the edges, they're not so sharp now. They're more of a rounded edge. And of course, the color is now this yellow color. So that's what the cat's liver could look like. Sometimes we can also give appetite stimulants to help. There's several new ones out. Mirtazapine has been kind of a good standby, but I know there's a new one out whose name I don't recall. Okay, our next disorder would be chronic hepatitis. So again, chronic inflammation of the liver, and this can eventually lead to loss of function, or what we would call liver failure. So again, a nice healthy liver should be dark red with these sharp edges. This color is okay, but you just see there's all this scar tissue. It's not nice and smooth anymore. It's just sort of weird, lumpy, bumpy, shriveled liver. You may have heard the term cirrhosis of the liver. That refers to that fibrosis that takes place. Most cases of canine chronic hepatitis are idiopathic. There's no bacteria, there's no toxin, there's nothing genetic. It just happened. We suspect sometimes that there's some autoimmune component. Another word for autoimmune is immune mediated. That means the immune system is attacking the liver. Leptospirosis can attack the liver. Leptospirosis can attack the kidneys or the liver or both. The adenovirus, if you look at your DAPP vaccine, that was to protect against a particular hepatitis virus. It's not very common anymore. Some dogs have a disease called copper storage disease that can cause hepatitis. And there are certain drugs like NSAIDs potentially could be hepatotoxic. That's not a very common cause, though. And again, it just leads to cirrhosis of the liver, basically, this fibrosis, death. Pressure starts to build up in the liver, and that's what causes fluid downstream to build up in the abdomen. And of course, the big thing is loss of function. Can't make albumin, can't make cholesterol, can't make urea, and so ammonia levels build up. There's other things, right? The liver makes a lot of things. It makes clotting factors. So now these patients can start to bruise and bleed in unusual ways. Clinical signs can be sort of nonspecific, vomiting, diarrhea, anorexia, right? But we mentioned icterus would be a little more specific, although you can have icterus and have nothing wrong with your liver, ascites, hepatic encephalopathy, ulcers can form. It's worth knowing that you have to lose a lot of liver before any signs of liver failure show up. It's similar to kidney function. You have to lose about 75% of your liver before albumin, cholesterol, glucose, before any of that would start to change. A definitive diagnosis would require a biopsy. We can sometimes make a presumptive diagnosis based off of history, blood work. There's a test we learned about called the bile acids test. Bile is what your gallbladder stores. Your liver makes it, it gets stored in the gallbladder, and then it gets dumped into your intestine to help you break up and digest fats. And it's really valuable. It actually gets absorbed back into the bloodstream, travels through the portal vein, and the liver recognizes it and recycles it. It's a really helpful substance. But when we do this thing called the pre and post bile acids test, we take a blood sample, we feed the dog a high fat meal, and then a couple hours later, we get another blood sample, and we want the lab to tell us the bile acids pre and post eating, or what we call pre and post prandial. And in a normal dog, there should be very few bile acids. But in a dog with liver failure, there'll be high bile acids and usually even higher bile acids after they eat because the liver just could not recycle them. And this is that process called enterohepatic circulation we talked about in pharmacology and physiology. And then I think the last condition we'll talk about is it's sort of unique to cats. Cats, well, it is unique to cats. It's a kind of hepatitis, but they can also get what's called cholangitis, and chol refers to the bile ducts. So cats can get inflammation of the bile ducts, and they can also get inflammation of the bile ducts and the liver. So that would be cholangitis and cholangiohepatitis. This can sometimes happen from bacteria. This little bacteria here in the small intestine may decide to ascend the bile duct into the liver. So there he goes, right? He's just going to travel up there. Sometimes there could be liver flukes. That's kind of rare. It could be idiopathic. And then here's the other new word to introduce. Sequela was one new word. This new word is comorbidity. And comorbidity just means an additional problem. So, for example, a patient who has cholangitis from, say, well, let me start over. A patient who has cholangitis may also have pancreatitis. For some reason, pancreatitis is not caused by a bacteria, but a patient could have, and this is really common in cats, because the bile duct from the, well, let me just ignore that. We can get inflammation from pancreatitis, and then that will somehow, that inflammation, maybe the trypsin ends up in the common bile duct, and now we have inflammation of the bile duct as well. So we often will see pancreatitis and cholangitis going hand in hand. And of course, that together can lead to hepatic lipidosis, and you've got a very full schedule. For clinical signs, I think I was going to write vomiting there. So again, kind of non-specific signs. Diagnosis, again, would be based on things like the chemistry panel. Again, to get a definitive diagnosis might be difficult. We may just have to make a presumptive diagnosis based on the patient may have elevated bilirubin, have icterus, be vomiting, be not wanting to eat. Um, Treatment consists of anti-inflammatories, and supportive care. Okay, so I'm going to create a little, that's the end of part one. So I'll create a little Quizlet for you. Give me a couple days. Well, no, I guess, hopefully by the time you look at this, there will be a Quizlet. So you could stop, go to Quizlet, and find the, let me try this one more time. I will put the Quizlet on Canvas. So hopefully by the time you see this, just go to Canvas and look for a Quizlet for the first part of this, okay? It'll be kind of a short one. But that's part one. And you know what? I'm just going to continue. Yeah, let's just continue on here to, well, no, let's stop just in case I have some technical problem. And so here's part one, and then I'll see you in part two.